And so do you have any knee pain right now?
No.
Have you had any recently?
No.
Ever? Not that you can remember. Any other signs or symptoms in your legs? Okay, so those are 4 questions. Now, of course, if you said yes to any of the 3, we'd ask them, can you specifically point to the area of pain? Because, especially with knee involvement, you know, the pain-generating tissues are pretty well localized, right? And at least you can get them down to, you know, 2, maybe 3. So the site of pain is very important. Okay, so there's that. There's our 3 questions. Then we have inspection. So we need to look at all surfaces. So I'm just going to have you stand here, face straight ahead. I want to look at the anterior surface. Now to begin with, I'm just going to use my usual scan for discoloration, abrasion, scars, edema, deformities. Right. Okay, so nothing there. Then I'm going to go back or I could do it as part of looking at specific landmarks as we're doing this. So if I have you just bring your feet together a little bit. All right. On the anterior surface, you should look at the patella. You should look at the height of the patella. You should compare side to side. Is it taller? Is one side higher than the other side? Or more medial or laterally positioned? Okay. So look at the patella. Look above the patella. Roll up your pants just a little bit for us. You can see the bulk of his vastus medialis here. Right? So that should be symmetrical. You can see the patella, but the whole space here, only half of this is bone. The other half is the patella fat pad. So it's the inferior half is really just a very large fat pad area. If you follow on down, you should be able to imagine where the tibial tuberosity is. Look for a very raised tibial tuberosity. That's a sign of maybe an Osgood-Schlatter's in previous decade. Okay. Look at where the joint space is. Now, if you see the side, the entire circumference of what would be the patella and the fat pad, about midway is where your joint line is. So look for signs of swelling there along the circumference. Scan laterally. Take a look at where the fibular head would be for signs of swelling. As you're coming around, there's a number of bursa that we'll identify with soft tissue palpation that will automatically come to mind. There's a suprapatellar bursa, a prepatellar bursa, 2 infrapatellar bursa. There's a bursa at the pes anserine. There's a bursa at the attachment of the iliotibial tract. Right? So, you know, these sites will automatically pop in your head if you see signs of swelling or redness. As you come to the posterior aspect, you'll see the patellar, or it's not the patellar, popliteal crease, and you'll see these 2 gullies here. Right? So these are outlined by your biceps femoris and your semitendinosus. You should be able to see them. They should not be filled with fluid. The creases themselves should be about the same height, which is a sign of the length of the tibia. Right? And or maybe malpositions of the ankle foot. Take a look at the alignment of the knee. So if you bring your feet together just a little bit more, we're going to ask ourselves, is there a genu varus or a genu valgus? So, genu valgus, let's start with that because that's most common. Is that knock knee or bow-leggedness? Genu valgus. It's knock knee. And it's usually associated with some changes at the ankle foot. It's commonly associated, right? So with flat feet, pronation, quite often you end up with knees coming together at the midline. Okay. Of course, with high arches, that's the supinated foot. Quite often you end up with a bow-leggedness, genu varus. Okay. There's also another alignment you want to think about, and that's the Q angle, quadriceps angle. So does anyone know what the lines that make up the Q angle are? What the points are that make up these lines? Anyone ever heard this before? Okay, so one line, and the lateral line, is going to run through the ASIS down to the middle of the patella. The other line is going to run from the tibial tuberosity straight up to the middle of the patella. And this intersection at the mid-patella is going to create this quadriceps angle, the Q angle. And the reason it's important is because it gives you a sense of how lateral to medial the femurs come, which tends to increase a valgus stress at the knee. And what makes it take it one step further, what makes it particularly important is with women who typically have larger Q angles than men because they have a broader pelvis, it increases the stress at the knee to the extent that they have a greater percentage of blowing out their knees when they play sports, ACL injuries. And they think it's directly related to the Q angle. It's increased Q angle. So, and then, you know, a male with a broader pelvis, an increased Q angle could have a similar sort of thing. You take a big Q angle with a flat foot and a genu valgus, that's like the trifecta. You're asking for knee problems. Okay? So there's that. Questions on the knee? Observation. Lastly is our range of motion then. We're going to have our patient come on over, they need to stabilize themselves. So you can have them hold onto a chair or the wall. So come on over here. I'm just going to have you come against the wall so you have plenty of space. Right? And there's 4 directions. There's flexion, extension, and internal external rotation. So let me just have you take your foot off the ground, a little bit forward. Extend your knee, straight. Take a look. It should be at least to 0. Some people go past the 0 point into 5 or 10 degrees of extension. How about flexing the joint? Okay, so if you bring your hip back a little bit, try to get a better angle. So it should go at least to 90, but most people can go past that, even up to 120. It's not as easy in the standing position, but it should be a pain-free flexion, and hopefully they can go past, it's my bad side, they can go past the 90-degree point. And then for internal external rotation, bring your hip up like this, and I want you to lock your foot and then turn it in and turn it out. So basically he's rotating his tibia. Go the other way now. And you can see he's got, and do it again, go the other way. You can see he's got a lot of tibial motion underneath his femur here. This unlocks the joint to allow him to do the internal external rotation. So you've got to flex the knee if you had it locked, and you're just moving the hip. So you've got to flex it to get your rotation. Should be painless. Should be able to go through the full amounts. We'll do our passive range of motion provocation testing when we pop the knee, just like we did the hip. Okay? So let's do this. So pair up.